Hello, everyone, and welcome to the Operation Miss podcast. I am so excited to be on with Dr. Rebeca Segraves today. Not only is she a new mommy, but she is also a very, very good friend of mine. And I am just so excited for you to learn from and glean from her insight today. So, the purpose of the podcast is to make sure that women and their families, and also providers, are equipped with what they need to prevent preventable complications. And this episode, I think, is one that is really going to give tools and tips for those who are ready to take notes. And so, without further ado, Dr. Segraves, I would love for you to please introduce yourself to the audience and specifically tell them about yourself, but also about your role in combating the maternal health crisis. So, what are you doing to make sure that moms are safe?
Oh, well, thank you so much for having me on, Dr. Sylvester. It's always such a pleasure to speak with you and just your audience. And I'm just such a huge fan, really, of the work that you're doing. And our paths really crossed, I think, around in 2021 or so. I would say that was where I think my work in maternal health was becoming more well known. But my background, I'm a physical therapist. I've been practicing in women's health for a little over a decade. And I'm, also just really just new to this space, and I'm learning as I go because I really wasn't treating this population before 2020. And so when I met you in 2021, I was just starting to understand how big of an issue the maternal health crisis really was. I didn't have the language for it or even understand it myself until I was working in a hospital on the maternity unit in 2020, just at the height of COVID, and treating moms after C-section and after um, labor and delivery complications, after high-risk pregnancy diagnoses. I was treating them when they were still pregnant on the high-risk maternity unit. And just that was my 1 year big dose of this is what the maternal health looks like in this country. And so ever since that, I couldn't unsee what I saw. Uh, I tell this publicly now. The youngest patient I've ever treated after C-section was a 13-year-old girl.
Mm.
And that just has stuck with me, really, just since that time, that we can't ignore the needs of these women. And I say this not as a slight to any profession that's fighting this fight, but I say that with regards to make decisions without them involved. That's what I mean by ignore the needs of women, is that when we decide what they need and what they don't need, what information they will have and what they won't have, that is ignoring their needs because you've never invited them to the conversation. So that's really my input in maternal health, is inviting women to the conversation about their bodies and about their recovery and about the experience that they want around the time of their birth. So that I can't say I no one told me, or I ignored what they, it's a direct ask of them, like, how can I serve you, or how can I help you, or what do you need, or what do you feel is missing? And so it's really, that's the gist of my work, is that I invite women to the conversation that we in the medical field are having about them and their bodies and about their future, quite frankly.
Yeah. And it's such a beautiful contribution, because if everyone invited them to the conversation, then everyone would know what they needed. And if everyone knew what they needed, then everyone would be responsible for making sure that they got it. And what a beautiful journey that would be, whether it's pre-pregnancy, during delivery, after delivery. If we center what mom and family need, then we can better support. And so it's interesting because, for me, I've always loved working with women, but it truly was my experience after my second delivery that called me to this work specifically. And sometimes I think that's what it is personal experience that really gets you to your mission. For you, it's like now, I mean, I guess we should just jump into it, right? You've had an experience now. You are a mommy now. How did that experience impact your perception of the healthcare system now? So you had a perception before based on what you did in physical therapy, but as a mom, can you explain how was it navigating the healthcare system in 2026, 2025, 2026?
2025, yeah. So my wife delivered by cesarean section in 2025. So December 12th, 2025 was the birth of our son. And I'll answer your question, but it may help for me to just back up a little bit before that, right?
Yes.
It was because we both actually worked in the hospital with women on the maternity unit. And it's just very rare to hear that from even a physical therapist. There's not very many of us in the country who have even the opportunity of working with moms on the maternity unit and then shortly thereafter in their home and virtual settings within the first week after delivery. Like, we usually hear of physical therapy if something's wrong down the road: pelvic floor issues, incontinence, pelvic pain, childbirth complications, back pain, pelvic pain, whatever it is. And so it was very rare for us both to be in those roles. And so we knew going in, there was a certain privilege that we had, and we recognized that we wanted everyone in the kitchen sink on our team. We hired a doula. We had childbirth education classes. We taught recovery to other rehab professionals, occupational and physical therapists who wanted to serve this population sooner, before they had complications down the road. And so we had the expectation that our recovery would be unknown. Like, we didn't know. I mean, vaginal delivery, would it be a pelvic floor injury? Would it be nothing at all? Would be smooth sailing? We had no expectations really on the recovery, but we wanted everyone on our team just in case. And we're both endurance athletes as well. So we knew we wanted you on our team just in case. And I say that really to say that you're familiar, and your audience is probably familiar of the study that showed that pregnancy is the equivalent of running a marathon a week. My wife is an ultra runner. She runs over 26.2 mile distances, like a 30-mile range and things like that. She's a mountain goat, runs in the mountains. We both live in Colorado, right? So we're, doing hikes that are over 14,000 feet. We're very, very active. And what I tell moms and what I tell therapists is that they're not seeking help because there's something wrong. They're seeking help because, as an athlete, if you're showing up to a race unprepared, you are going to suffer, right? You're going to suffer in some form or fashion. You would never show up to a race, right, unprepared. You would show up, likely with your team if it's an endurance race, like what we run, and you would have all the resources. You would have prepared. And pregnancy was the equivalent, at least in a study done, in 2019, that study likened pregnancy to the equivalent of running a marathon a week for 40 weeks, right, in terms of the energy expenditure. So that is really, really important to answer your question of like our background. We knew going into this that there was the expectation that Jenna's body was going to be working at the equivalent of a marathon a week. So we wanted you to be monitoring us. We wanted to have a doula to support us. We were planning for a home birth with a midwife. And so we were doing everything that we could with you monitoring us, with us tapering activity on days where we didn't need to be as active, things like that. Like, we were in it together. Just understanding that pregnancy in of itself, there were changes that were going to have to be made. We weren't going into it like, oh, we're healthy, we're vegan, we're active, we're good. No, we felt good because we had such a robust team. And so, I mean, we could talk about this in detail, but kind of fast forward to 12/12, Jenna went over 42 weeks. And in the state of Colorado, and probably most states around the country, I actually don't know the nationwide laws, but in Colorado, no midwife in a home birth setting or even a birth center is able to deliver your baby. You have to deliver in a hospital. And we found out later that it was likely that maybe, at least this is what probably helps us sleep at night, but it was likely that baby was not going to be born vaginally because Jenna's water had broke, and they believed that his head, the way it was actually shaped when he was born via C-section, it was shaped in a way, and he was so wedged in to the left side of her pelvis that it was likely that she would not have delivered vaginally. But leading up to that, we didn't know. We labored for 32 hours with the expectation that we could still have a vaginal delivery, not the setting we wanted. It was going to be in the hospital. But we did everything in terms of spinning babies, position changes, all of it. But, his heart rate just could not stay in the 100s. It was decelling to 60. And when they said the term acidosis to me later on, I just panicked because I know what that means. I mean, he was in severe distress. So she had an emergent C-section. And I think, to answer your question full circle, the postpartum experience, the labor delivery experience, being on that side of it, even though I cannot tell you, Dr. Sylvester, how many labor and delivery notes I've read and then compared them to what the moms actually said, and just heard so many stories in my time working with women in the hospital after birth, and the stories that they had that were so fresh. I still don't think any of that really prepared me for actually being on this side of it. And I think that that's really important for your audience to understand, is that I am a well-resourced individual. Like, I am a well-resourced individual. There was absolutely nothing in our way of getting all of the resources that we needed for, pregnancy and postpartum. And being on this side of it, I have to be quite honest, is that the kryptonite for both of us was sleep deprivation during labor and delivery and postpartum. Is that you make decisions or you say yes to interventions that you would never say yes to if you had your full faculties. It is truly like running a race where you are depriving yourself, your body, of energy, and then having to make races in terms of, like, what path do I take now? I can't, there's no marker. Is it right or left? Is this the right? So it felt, quite honestly, nothing like I've ever experienced, right? In my most exhausting race, nothing like I have ever experienced. And I wasn't even the one on the table. I wasn't even the one that was delivering. And I was still just the support person, just only imagining whatever is happening to me is happening about 30 times more for Jenna. And it's very disarming. And so, I mean, the events just surrounding that, it gives me a different perspective of the healthcare system, is that I think I would have had even more, I don't even know how to explain this, but I think now, being on this side of it, I would have had a backup doula for my backup doula. I would have paid for you to come to Colorado. I would have taken you from your family. I mean, if money was not an issue, I think to me, it's like, you can't have enough support. But to me, I could never imagine going into the hospital by yourself and just your partner and just pretending that the hospital works for you. They don't.
Yeah, they don't. And, you said something, and I really want people to hear this. I didn't know this. Subconsciously, I guess it happened because when I worked at the hospital, I chose all of my providers for life. So I said, if I'm going to live in Macon, I need to read all the doctor's notes, like really pay attention to how they treat, how they love, how they serve. And so I had a cardiologist, a kidney doctor, a dietitian, a social worker. Like, I had all of them picked out, but for my older age. I didn't think I'd be needing them after my second delivery, right? But as soon as my provider said, you're Black, you live most of your life in the South, you probably had high blood pressure before you even got pregnant, your kidneys are never going to heal. I mean, he's saying all of these things, and all I'm thinking is, okay, I got to call Dr. Ellis. I got to call that. Like, I knew he's not on my team, right? Because he doesn't even believe in my body's ability to recover. But I had what do they call those? Oh, girl, we're old enough to know what a Rolodex. A Rolodex full of providers that I knew I could count on. And I'm telling you, it was as soon as I made the call, he said, you don't even have to worry about getting a referral. You just come in as soon as you can, and I'll make sure I take care of everything on my end. It was the most incredible experience. And so I think that it's really neat. Just like you and I work for moms, and we are the healthcare system, there are providers who do work for moms, right? We just have to make sure we know who they are before we get into a situation where we need them. And so you putting your team together ahead of time, ahead of the pregnancy, ahead of your postpartum journey, it really has made all the difference, right? Imagine if you were scrambling around for an occupational therapist to come in, or you didn't have that, you didn't even know me, you didn't know that we existed. It would have been just right. It's disorienting when you have people on your team. Can you imagine when you don't? And so for the people listening, the moms listening, the families listening, get your team ready before you ever get pregnant, and have a list of cardiologists, kidney doctors, social workers, nonprofit organizations, occupational therapists, physical therapists. Just have them all, because you never know what you're going to need. And so you were prepared in that way. And it still feels like you're not prepared when things go in a way that you didn't expect. So let's talk through your postpartum, because people need to know why things are not just missed in postpartum, but how they are dismissed. And both can lead to a negative outcome, right? A lot of times when you look at CDC research and they say, 80% of pregnancy related deaths could have been avoided if early warning signs were not missed. But the problem is sometimes that they're dismissed, or they're normalized. And then you go home sometimes with a peace of mind, because you'd rather listen to a provider say, you're fine, you're just postpartum, than to actually embrace the reality that something could be wrong. And that's what I love. That's what I love about data. It's not just smartwatch data, it's thermometer, pulse oximeter, blood pressure. Of course, if you do take your steps, your heart rate, your oxygen readings, your lab values, those are things that you can't really argue with. And when you have the data, it really does give you a different sense of determination when it comes to being heard. So can you talk us through your postpartum period so that we can really help people see how things can seem okay, right? When you're at the hospital and then you go home and it's completely different. And the interesting thing is that most of the time, people are not going out of their house a lot postpartum unless they have to. And typically that's for a newborn baby visit. And then otherwise, it's just their choice. But you all had a completely different situation and story. So can you talk us through your postpartum period?
Yeah, absolutely. I mean, and it's fair to say, just saying to your audience, yes, we labored for 32 hours. We labored and had IV fluids, right? So we were placed on antibiotics because Jenna's water broke before she went into labor, and outside of the hospital. It actually broke in the clinic visit that we were just having with a midwifery group and an OBGYN group, because we were 42 weeks. We were post-date. And so because of that, we actually had water break in the office while they were doing the ultrasound. And so we went to the hospital that day, and antibiotics were started every 4 hours. And because baby's heart was not even handling early labor, every time his heart would drop, she would be given another bolus of fluid. So all that to say is, in our postpartum experience, we seem to be okay, right? Despite the fluids for 32 hours of labor, and then the C-section that was completely unplanned, emergent, we were actually doing okay, up and walking, within hours, pushing the bassinet, which I didn't even know and this should be said immediately, is that Jenna should not have been pushing the bassinet, but we were under the impression that if she were pushing, she had something to hold on to. And that was later, our occupational therapist just later helped us realize that was actually more energy expenditure. So, a lot of things that even I didn't teach, right? And so we left the hospital with Jenna's blood pressure around 104/76. That number sticks out to me because it was very near her early pregnancy or even pre-pregnancy baseline. Like, she actually pre-pregnancy was in the 100s to about high 60s or low 70s. That was actually her norm. And so we were very happy with a blood pressure of 104/76 the day we left the hospital. And, she was swollen, definitely still, but we were thinking, you had a lot of fluids and a C-section, swelling was normal. And it really, I always say the second night is the worst with baby. And yes, it was. So, I mean, it was definitely difficult in terms of just being home those first few nights. But by the third day, I remember Jenna, and we were at home, she saying, we acknowledging her swelling just was looking worse. And I was just thinking kind of all the things that we teach around this time, lay flat, your C-section incision is, also kind of a barrier to flow between your legs and your heart, lay a little bit flatter. It felt really good to do in the hospital. She was doing all the exercises that we normally teach moms, and I was doing the massage, to her abdomen, and that was just feeling really, really good. Not on her incision, but her abdomen in terms of like helping her bowels move and just everything feeling really good. There's a specific type of massage that I teach therapists to do and I teach moms to do. And so all of that was really feeling good. And by day 3, her legs were visibly swollen. Like they were more so than I would expect. If all of these interventions should be working in the right direction, why are her legs getting actually more swollen? And so she was pretty adamant. I was a little more hesitant, but she was adamant. My friend just went through, had a C-section, and she just did a short walk to the mailbox and back. Didn't even make it all the way to the mailbox. I want to go outside. It was really sunny. Ironically, in mid-December in Colorado, it was actually pretty sunny. And I agreed, even though I'm like, we're totally breaking the 5-5-5 rule. But even at that time, right? Like stay in bed, stay on the bed for stay in bed for 5 days, stay on the bed for 5 days, stay around the bed. I'm like, we are going out of our home, which is about 18 steps, to go outside and then come back in, which is about another 18 steps. Is this really the smart thing to do? And it really wasn't, but that's hindsight, right?
Yeah.
And so we went outside, and Jenna lasted probably 2 minutes before she had to turn around. Like she could tell something was wrong, and so could I. And so we took her blood pressure. Something just told me, let's take this, because we hadn't really, I honestly, I don't think I was taking it since we left the hospital. And so we took her blood pressure, and for the first time it was over 130. And definitely it was like 130/90. I remember specifically. And we were shocked because, again, Jenna's an athlete. We had never even seen it. Even during pregnancy, we had never seen diastolic over 90. I mean, it was just something, it was just like alarm bells were ringing. And so I remember reaching out to you. You were one of the first people that we reached out. And then, of course, our provider, the surgical group, the OBGYN group. And because it was not over 140 systolic, they were kind of like, let's just watch it. No medication was prescribed, nothing was prescribed. And which was entirely frustrating for me.
Yeah.
But you, on the other hand, because you were monitoring us, you had a very different, I remember you texting me. It was a message I'll never forget, but you were saying, because you were watching her, heart rate wasn't looking like too alarming. It wasn't like very high or anything like that. And stress levels weren't too alarming either. And you explained to us that those values are very inconsistent, unreliable, right? Immediately postpartum. But blood pressure is king. I remember you writing that. Blood pressure is king. And I was like, okay. So I started diligently assessing Jenna's blood pressure from then on. And we finally got her midwife to put in an order for labs the next day. And I remember this like it was yesterday. You and I were talking, and you were like, is there any way that you could have a phlebotomist or the labs come to you, like a basically an in-home services that where they could do labs? And I couldn't find one. I was just kind of panicking because I wanted to see the numbers. I wanted to see the labs. I wanted to make sure we weren't trending, because every time I took Jenna's blood pressure, it was a little bit higher. It was a little bit higher. And I didn't, for whatever reason, I don't even know why I didn't at the time. I wasn't checking her heart rate, but she later told me that you were seeing her heart rate just on the monitor starting to dip as low as the 30s. And you had told her that it's normal postpartum for the heart rate to come down to maybe your baseline. It's not normal for it to go below what your baseline was. And so that next day we got labs. And I remember specifically you had told us to ask for them to do a BNP. And they didn't, right? Which was so frustrating because when the labs came back, they weren't concerning, to the team. But Jenna's blood pressure continued to rise. And during her midwife visit that day, the 4th day postpartum, midwife came in the morning, and Jenna's blood pressure was 150, over 150 over 94 or so. And I mean, we still talk about this to this day. The midwife never didn't suggest we go to the ED. By that time, Katherine, when we were sharing the numbers with you, you were talking ED. Like I think you should go. Midwife wasn't. So then we called our OBGYN, the office that did our surgery, because this was the home birth midwife that we had hired, didn't have a home birth, but she was providing postpartum care for Jenna and the baby. And she didn't seem too concerned, was willing to watch and wait. But to me, at that point, it was like, watch and wait for what?
Yes.
We're already 140 over 90. What are we waiting for? I'm not about to watch my wife go over a cliff. What are we waiting for? So I just started to just kind of monitor, start to keep logs, call more people. And finally, we got our OBGYN office to prescribe Procardia, to start to reduce Jenna's blood pressure, because by that point we're consistently in the 150 systolic, 90. And Jenna wanted to know, well, how soon can this blood pressure start, working? They said, within a couple hours. Right? And so basically that night we had our highest two readings, 1 over 160 over 100. And the reading that took us to the hospital was 170 over 94. And that's when we were just we just called it ourselves. At that point, we had the first dose of the medication. We didn't want to wait until the morning for that dose to kick in.
Right.
And so I made the call just based on everything that you were kind of, recommending for us, the fact that they didn't take a BNP. I knew that was an indication of heart stress and potential heart failure. We were already starting to get heart rate readings into the 30s, so it was dropping below Jenna's baseline. It was just too much information to be if none of y'all will tell us to go to the ED, we have to take ourselves.
Right.
And I felt so strongly, and Jenna did too. And at that point, I didn't know this. I found out later, but remember I told you, in the hospital, it felt really good for her to lie flat. Mm-hmm. At that point, she couldn't lie flat. She felt a whooshing in her ears, and she felt a lot of chest pressure.
Yes, and love that you brought this up. Let me pause you here before you get to the ED, because I've taken some notes and I want people to really hear this. So when Jenna reached out, I asked her to try to lay flat to take her blood pressure. Normally, when you're looking at research and the way that they're looking at numbers, the person's sitting, they're relaxed, it's been 5 minutes, their arm is elevated on a surface, it's at chest level. And so you go through and you're doing what you know you would do in a hospital setting, or not in a hospital setting, but in a doctor's office. So that's typically how people will take their blood pressure. But I asked Jenna to take it laying down because if it's truly activity related, if it's blood pressure that is going up because you're up and you're doing a lot, then theoretically it should be lower when you lay down, and you should not be uncomfortable to lay down, right? So when she said that her blood pressure was high laying down and she couldn't lay down because of the pressure, anybody listening, that's a red flag. Okay. And so normally, and two, just thinking about preeclampsia, in this case, it was not preeclampsia for her, but that's what you'll notice too with preeclampsia, is that it doesn't matter what position you're in, your blood pressure is not going to be low, and it will continue to elevate until you have intervention, right? Whether that intervention is medicine or, going to the hospital, or sometimes it will be rest. But in theory, laying down, blood pressure should be low. If you're running, blood pressure would be higher. If you're sitting, it's going to be a little bit higher. And so recognizing that that is an emergency, that is something that needs to be looked at right away. The other thing is Jenna's norms. So she and I were talking about this the other day, even and with her occupational therapist, about the stress on a Garmin watch. And so her OT was like, well, what is, trying to have me explain what is low stress, rest, what is moderate, high. And I said, well, for the watch, for Garmin, 0 to 25 is rest. 26 to 50 is low, and then 51 to 75 is medium, and 76 to 100 is high. Okay. But for Jenna, 0 to 20 is rest, 20 to 30 is low, 30 to 40 is medium, 40 to 50 is high. And so there is no what is the standard for stress for Garmin. It is what is the standard for stress for Jenna. And it's the same thing with blood pressure. Because if we look at blood pressure, and we really have to understand why 140 over 90 is too high. It's like severe high blood pressure for Jenna, severely high. It's not moderate, how you would look at it for someone whose baseline is 120 over 80, right? Because if you look at the percentage jump from 120 to 140 versus 80 over 90, and then you use that same logic to come up with what it would be for Jenna, at 128 over 78, that bothers me. And so the day before, she was at 130 over 90. She was at 120 something. Do you remember that? And I was
Yeah.
that's not normal. We can't normalize it just because she's postpartum. And so I really want people to start thinking there isn't a lot of guidance about what an increase in blood pressure should be concerning. But for us, what we've noticed is that every time we have caught preeclampsia, every time over the past 4 years, it has been with someone's blood pressure in the 130s over 80s. It has not hit 140 over 90. But with each of those deliveries where preeclampsia arose, they went on to have vaginal births because they were able to pivot, course correct, get the medication that they needed. It was during pregnancy. They were able to go on bed rest, relative rest, not bed rest, excuse me, relative rest, where they're not shooting for 7 to 10,000 steps. They're shooting for whatever their body is able to tolerate, which is sometimes 1,500 steps a day. But at least they're moving, right? We're not trying to lay around and wait for blood clots to find us. And so if you're listening, understand it is important to know your baseline and then what would be concerning for you. Because if we saw somebody else's heart rate in the 40s, we'd be like, oh no, but Jenna, that's her baseline, right? So we have to figure out, well, what is concerning for her? What is that number that says, I don't care what anybody else says. I will go from provider to provider to provider until I am taken seriously. Because what's happening now in this country, and I'm sure it's happening in other parts of the world too, but we're here and we know what's happening here, is that women are being dismissed just like Jenna was. And so her symptoms were being ignored, right? Her swelling, her blood pressure creep her heart rate decreased. And it's like, well, you checked out with the preeclampsia, go home. You checked out with preeclampsia, you need to rest. And the reality is, if she had rested and went to sleep with that elephant feeling on her chest, what would we have woken up to the next day? It is that we really have to be okay leaving in the middle of the night with a newborn to get the care that we deserve. And so when you tell your story, you really, and you talk about the exhaustion. Everybody who has had a baby knows it is absolutely exhausting. So to take that extra step and say, I'm going to go to the hospital at night when you could possibly try to get rest, that is a hard decision to make, right? But you made it. And because of that, she made it, right? But please, so take us to the hospital, because when you go to the hospital, you expect that you're going to get what you need, right? There are plenty of people there, hospitalists on call for every single discipline that could possibly be needed. So you think you go to the hospital and you would get what you need. What did we get when we went to the hospital?
Yeah, so we went to the OB-ED. Like we went to the emergency department for obstetrics specifically. And we were so careful with this hospital because there's several in town. And we worked at this particular hospital. It was actually the largest maternity care hospital in the state, right in our home, right in our backyard. I mean, it was a 30-minute drive, but it was further from, same system, the hospital that was closest to us. But we wanted to go to this one because really we thought their obstetrics care was bar none the best in the city, even though we didn't actually end up delivering there. And that's just an aside. We felt strongly like we wanted to eat during labor and delivery. So we went, about an hour up north to a hospital that we felt that we could get care, the labor and delivery experience that we wanted. And so because of the emergent, nature of this visit, this was the best hospital that was closest to our home in an emergency to go to. That's what we thought. And because Jenna registered now over 170 over 94, we were like, obviously, yes, it's close to midnight. We both have had little to none sleep, even prior to delivery. But it was absolutely, I wouldn't even second guess that. I was getting in the car, we were packing up our baby. And we even packed a suitcase because we didn't know. Like we just thought, if there is anything that's wrong and they admit Jenna, we wanted to have all these things. So we took a little bit longer, but we didn't take that long. It was like, let's get everything we needed and let's get in the car, let's go. And so we arrive at the OB-ED and they check us in really fast. It's very quiet. I think we're like the only, patients they have. And they start running the labs, start taking Jenna's blood pressure. And thankfully, I say thankfully, still high, but it's in the 150s. It's not as high as 170, but still the 150s to high 80s. And for us, that's just so beyond Jenna's normal, but they were completely unbothered. They were just so this is not a big deal. You didn't wait long enough for the blood pressure medicine to kick in. Like you were just prescribed it. Why didn't you wait? And so the OBGYN walks in, and by this time, Jenna's second blood pressure reading is now 160 over 90 something. And so the nurse even acknowledged Jenna's in the severe range. Like now we're actually we're seeing what you're seeing, but yet her labs were normal, like no preeclampsia. So the OBGYN proceeds to chide us in a way that I've never been talked to by a provider. Now I've gone to blows, professionally. I've gone to blows with providers who are like, it's not that big of a deal. I say it is. We go toe to toe, but in a professional way. This was unlike anything I've experienced because I was now on the patient side. And she's basically telling us that we should not, specifically tells us, explicitly tells us, who told you to take your blood pressure? Who? And then, we answer, we kind of even stutter, like I'm stuttering now, like we're physical therapists. Like, what do you mean? We're healthcare providers. Well, I mean, like, what do you do? We're physical therapists. Well, who are you under the care of? When we tell them it's a midwifery practice, but, of course, an OBGYN of that practice did the surgery. Well, I don't know their training. I mean, she just starts going in on midwives don't have the training that, OBGYNs do. She never tells her patients to take their blood pressure. I tell my patients to not take their blood pressure. She proceeds to tell us the anatomy and physiology of pregnancy and the anatomy and physiology of postpartum recovery, and blood pressure goes up and down. This is not a high reading. Totally, like, just, you shouldn't take your blood pressure. Go home. You're on a medication dose. She doesn't change the dose, nothing. She's ready to discharge us. And so Jenna and I mean, I feel like in my mind, I know I need to see someone else, but how will I actually get this provider to refer? Like, I'm starting to strategize. Like, I cannot come out my skin at this woman like I want to.
Yeah.
But I need to figure out, we need to see someone else. And thankfully, oh my gosh, like, Jenna remembers, like, when I lie flat, because I mean, it's something just triggers like her memory. And I don't know if it was something about, well, I think we kind of pressed a little more, like, well, why is her blood pressure dropping, but her heart rate is falling? And I think she tells me later on that I've said something about heart failure, and it clicks with her. And so she tells the OBGYN, when I lie flat, I have this pressure on my chest. And in that moment, the OBGYN looks at us and says, we don't do anything with the heart here. You're going to have to go to the main ED. And I'm telling you, that's the best thing that woman did for us, was to send us to the main ED. Dr. Sylvester, I'm not joking. Like, we have to check basically out of the OB-ED, and the main ED is a whole different check-in process. And that's where the real is. Like that, I mean, the OB-ED was kind of fancy. It was nice. It was beautiful. The main ED, we have a 4-day-old newborn. We're trying to find a corner to stand in. Like, people are coughing in there. I'm just like, this is the worst possible experience. Right, but we couldn't get help in the obstetrics emergency department. I'm thinking, like, how can you send us somewhere else? Like, what do you mean you can't send a cardiologist up here?
Like, Rebecca, I did not want
we have a newborn. So anyway,
but I'm like,
yeah, and I'm sorry to draw this out, but Dr. Sylvester, I'm telling you, like, your audience, like, they need to realize, like, we are healthcare professionals. We are watching her blood pressure rise. We're watching her heart rate fall. And she tells her 4 days postpartum after C-section, when I lie flat, feels like there's a pressure on my chest. And she says, we can't do anything about that. What later happens in the main ED pulls this all together is because they run the lab that you had told us earlier that day, even probably the day before, if I'm going to be honest with you. You had told us pretty early on, when Jenna's blood pressure first started to rise, get a BNP done. The BNP in the emergency department is 1650. The highest I had ever seen professionally was 750 on a woman that was 3 days postpartum. And she was diagnosed with acute heart failure at that point. Jenna's was 1650. I had never seen anything clinically over 700. Obviously, other professionals listening to this have seen much higher. I'm just saying, from my experience of working with postpartum moms, I've never seen anything higher than the 700s. When they told us that Jenna was 1650, the emergency physician, I'll never forget this. He starts saying, my family member suffered with peripartum cardiomyopathy. It is the worst. And I'm thinking, like, so you're just basically giving us the diagnosis. He's admitting us to the hospital. They're going to do an echocardiogram. And we basically are just in our heads preparing for peripartum cardiomyopathy. We are now in acute heart failure. And we're just shocked. And so I say this and pause here, is that we were so close to being discharged by an OBGYN in the emergency department. Had Jenna not told her that she was having chest symptoms, they would have sent us home. At that point, when Jenna's being admitted, they give her an IV medication that completely plummets her blood pressure. It gets down to like 116 over. I remember taking a picture, but we were out of like the 90s. I think we were in even the 70s. Like, it plummets her, and just drives her blood pressure down. And thankfully, yes, because we were just, that creep was just getting so high. Her highest was 181 over 90 something, right? I mean, and you think about the norms that they have for people and the complete disregard for Jenna being the athlete that she was. I shudder to think, had we went home that night, I think of the worst, right? And so I'm thankful that they admitted us. They gave her that vasodilator. They drove her blood pressure down. She starts going to the bathroom. Her own body, like her body, I think it had something to do with that vasodilator, because she just starts peeing all night. Like, we're up all night and Jenna's going to the bathroom. So her body starts diuresing, right? And getting rid of fluid. And the echocardiogram the next day was negative. Like, it didn't show heart failure. So we think we're in the clear, but really, to bring you to present day, Jenna has still been dealing with just diastolic hypertension. You have been with us every single day. I don't think that there has been a day that has passed since we really delivered that we have not spoken to you and just been keeping you up to date on our numbers, on our blood pressure, all of it. But we have seen well over 7 providers. We've hired our own direct care, primary care. We fired the one that was taking insurance, and we just said we're going subscription. We're going to pay cash, because it was quite obvious to us is that we were going to have to pay for the care for someone to work for us. We needed a PCP that we could call, that could order labs, that could order this, that could order that. And so basically anything you told us, we would tell the PCP, and the PCP would do it. Because we also just didn't have the knowledge that you do, right? Like, yes, we're all physical therapists. Jenna's a physical therapist. I'm a physical therapist. You're a physical therapist. But Katherine, you were advising us on things that our medical team wasn't. And so it was easy to just to relay. I was just like, Jenna, what did Katherine tell you? Okay. And then tell the PCP what Katherine told. Like, it was easier to just relay the information, because you were coming up with research articles and this and that. And we would see their faces when we gave them the information. And we were like, okay, that clicked, that worked. Like, they'll listen to her. And so it just became quite obvious that now we're 7, 8 providers in terms of visits, is that we are in this for the foreseeable future, but the fight is still not over, because we're just really uncomfortable with this being a new norm for Jenna, who is thinking like an athlete, like she wants to get back to these activities. So it's been really just touch and go. Like, we're not in the clear yet, because we don't have blood pressure readings that make us feel like this is getting back fast enough. It feels very much like the providers are okay with the numbers because they're not as high. And to me, it's like, but this is still higher than Jenna's norm. So that's just where we are, quite honestly.
Yeah. So I just have to say this, and for people listening, you have to understand this. If you're ever discharged from a hospital, you can always go to another hospital. If you're discharged from the main hospital, you can go to the ER, to the ED. We have to make sure that we're safe when we're going home. And that should happen before we leave the hospital, right? But sometimes the symptoms just don't arise at that time. And we know that blood pressure is expected to increase on day 3 to 6 after delivery. When they say increase, that does not mean that it's supposed to be severely elevated to the point that you ignore what is abnormal. Because in the hundreds of moms that we have monitored, we have only recommended BNP for 2. And so it's not that, well, I'll take that back. I do believe everyone should have a BNP. I really do. I know that there are some things that it's like, oh, we just draw these things routinely, and some things they should be specified. But we have so many women where just having a BNP reading would have been helpful, right? And there is an organization that was erected because someone's sister died 5 months after delivery. And we know of moms who are on mechanical hearts because their fluid overload was ignored, right? And so BNP, I think, would help hold providers accountable for doing what needs to be done. And I think it's better to have more information than to have too little information to make a decision off of. And so the interesting thing about Jenna's presentation, though, which is why I think they just thought preeclampsia, is because if someone is in heart failure, you would actually expect that their heart rate would be higher, fighting, right, trying to like still deliver oxygen and stuff like that initially, and that blood pressure would be lower. But when you look at Jenna, and I just think about it, even with like her kidney function and her heart function going into fluid overload, her body is going to fight harder than somebody who's normal. Or somebody who, and I mean by normal, I mean someone who just does their day-to-day lifestyle, or even someone who is sedentary. Can you imagine if Jenna was not an athlete and she was going through this? I just don't know that her kidneys wouldn't have been able to keep up with all the extra fluid, that her heart would have been able to fight as long as it did before it dropped into the 30s and got tired. Like when people's heart rates get that low, there's a reason for it. And that's what we have to understand, that it doesn't just drop because it wants to. It drops because there is so much pressure on it that you're literally having to fight to pump every single time. And so when you don't have a lot of pressure, it's able to flow just like normal. But when you do, it's harder. And she survived that, right? And so we have to really put things into perspective and think, if we are only used to seeing preeclampsia, my husband says this all the time, and I think I really got it with Jenna. It's like if you have a hammer, I forget how he says it, it's like everything looks like a nail. So like you're just gonna hit everything because that's the only tool you have. And so when blood pressure spikes postpartum, I feel like everyone thinks preeclampsia. And if you're only looking at blood pressure, it seems like that kind of makes sense. But if someone has chest pressure and a lower heart rate, we have to start thinking BNP. We have to start thinking fluid overload. And then, like you said, she was visibly swollen. If you're listening, it is, when people say it's normal to be swollen, it's, if you have swelling in your face, in your hands, that is not normal. It's just not. It's like the fluid is not doing what it's supposed to do. It's not leaving as quickly as it's supposed to leave. If your legs look like elephants and your feet, like you press your thumbs into your feet and there's an indentation there that doesn't go away for a while, that is not normal. And so it's not to say that in every case it's fluid overload and you're going to have blood pressure medication and stuff like that. It could be that there are other interventions that can be done. I went to someone's house a few days postpartum and they were swollen and they had higher blood pressure. But with positioning, with massage, all the things that you were talking about, by the time I left, her blood pressure was back to her baseline. And so for some people, that's all the intervention they need, that you need compression socks, or if you like them, or if they're needed and necessary. It's like there are tools that we can use, but the problem with heart failure, when someone is going into heart failure, is that anything that you do to send fluid back to the heart makes it worse. And so we don't want feet elevated above the level of the heart. We don't want compression sock and sending fluid back to the heart because it's going to overload it. It's sending it back faster than it's able to deal with it, right? And so we have to understand we cannot be at home figuring it out on our own. That's what I want to get to. If this is happening to you and you are being ignored, go to a provider who will hear you, because that is the only way that we save ourselves. I don't think that with the pace of healthcare, with the amount of people that are being seen, even how you explained it, you should not have had to wait in the ED. It should have been, if you had to go down, you were given some type of an assistive device to go, number one. But number two, it should have been that you're seen automatically. You're not out there with sick people. And so even the way that that was done, that's not acceptable. And not everybody can leave, though. Imagine, I mean, it's like you said, you had to do what you had to do to get the care that you knew you needed. And thankfully, you got to a provider who had the tools that were specific to what Jenna needed. And it's a blessing. And it's sad that some people don't have access to that. Some of our moms are driving hours to another ED, right? And you got to have it done there. Now, the other thing to know is that you can't always get a direct primary care doctor. And that has been a really good tool for us, like really good partnership for us. So add that to the list of people that that you want to have on your team ahead of time, because a BNP is a quick lab to ask for and to get done. And then a mobile lab can come and do that. And so in your case, like you said, I mean, we called around, tried to get people to come, and it was going to be later than the time that you had already scheduled to take Jenna. But the reason that I didn't want you to leave, and I want people to hear this too, is that when you get up and move around, your blood pressure is expected to go up. And in that day 3 to 6, if your blood pressure goes up, and it's really up through day 14, but your blood pressure management system is not what it was prior to delivery. And so our blood pressure management system has a harder time getting it down. And that's why we recommend, it is the only guideline, the only protocol that Operation Miss has. And it is that within the first 6 weeks, you do not take more than 4,000 steps. And so you're watching your step count and making sure that you're not going above that, sleeping at least 5 hours a night so that our kidneys can rest, our heart can rest. And it's hard to do if you're breastfeeding, right? And so we understand that we can't do it perfectly, but we strive for it, because overnight our blood pressure goes down. It has a natural dip that takes place, but that dip will not take place if we're not getting the right amount of sleep. And so for moms who are up with the baby by themselves, can you imagine you're up when the baby wakes up, you're pumping, trying to do that before you put the baby back down, you're only getting 2 hours of sleep. That person who already is predisposed to having higher blood pressure, whether it's because blood pressure spiked during pregnancy or they received a ton of fluids like a lot of moms do, then they're not getting that nighttime dip like they should. And so the 5 hours of the sleep a night, continue to drink at least half your body weight in ounces in water. And we do lose a lot of fluid after we have the baby. We should. And so it's like, we should be down a few pounds. We should have less fluid because the body's constantly getting rid of the fluids that we don't need anymore. But we're still drinking half our body weight in ounces in water. We're eliminating any unnecessary stress. We're accepting any and all help that is offered to us, as long as the person providing it doesn't increase our stress. But those are things that we stand on, because when we do that, we have seen that when moms do that and there is no underlying complication, they don't go back to the hospital, right? They don't get readmitted. They don't have complications. And so we have to abide by that. The other thing I want to go back to is the 2-minute walk, right? Because you said something and we missed it. It didn't come up in conversation, but you were told to go home and walk 3 times a day for 10 minutes each, right? And a lot
by
of
the OBGYN, yeah, but in the emergency department.
Right. And it's like 10 minutes, when after 2 minutes, she was tired. And you could tell symptomatically that she needed to go home. And we know that walking is going to increase blood pressure, and blood pressure is already high. We have to start thinking the way we treat people post-surgery, post-back surgery, shouldn't even be compared to what's happening postpartum. We shouldn't even put it in the same category, because that's what people are doing post-back surgery, right? We're getting them up, we're helping them walk around, we're telling them walk to your mailbox 3 times a day the first day, to your neighbor's mailbox 3 times a day the second day, to your next neighbor. We're pushing mobility. With post-pregnancy, we have to think, what is the individual person's mobility level? And for Jenna, it was not 10 minutes 3 times a day. We would have been even deeper in trouble if she just followed that recommendation blindly. But when you are afraid, when you think that what a provider is telling you has to be right, you do it. And you see people collapse and die after doing it. And so
I will say this. I mean, I think that also is a result of us putting doctors on a pedestal, right? I mean, I do. I mean, I think that culturally, we've been conditioned to allow people like that to make decisions for us that we know deep in our soul, this is hogwash. Right. Like, what are you? We just did this yesterday and we made it 2 minutes, and you are telling us. And so in my worst of worst incidences where I'm just like completely sleep deprived, I could tell that this woman is just responsible for probably however many women suffer, unnecessarily postpartum. Like I could tell, and it was later confirmed that this provider is horrible. Reputation is horrible. I was even encouraged to report. I mean, it was just it was like the amount of information I found out about this single provider taught me to teach others that we have to stop culturally putting doctors on a pedestal when we know our body. I even heard a quote from somewhere. I cannot tell you where I heard this, but they said that the doctor of the future will be the patient, meaning we will arm ourselves with the people and the resources that will give us the information to make decisions about our body that we will never in our right mind let another provider make without that same data. That doctor was telling Jenna to go home, not knowing at that point what we knew a few hours later, that she was in acute heart failure, and she was telling her to go home and walk 3 times a day for 10 minutes. She would have killed her. And so when you hear a quote like that the doctor of the future will be the patient, it will be someone who has 24/7 remote monitoring. It will be someone who's armed with a team like you and what your company does for people, and they're getting that data in real time to basically say, my heart rate is going into the 30s, my blood pressure is going up, I'm seeing this swelling, I'm getting this information that is telling me this is what it likely is. I'm going in and I'm telling the provider what I need, versus allowing a provider to dismiss us and tell us something that could kill us. So I will say that I stand on that truth, is that we are doing this to ourselves because culturally we're allowing ourselves to be putting these providers on pedestals when they don't have the time, they don't have the resources, they don't have the information about you individually, and they're just making these blanket statements because they're overwhelmed, overworked, they're tired, and no, they don't know all. And so we have to stop doing that. That's on us. That would have been on me. I would have taken full responsibility had I gone home, which I knew I wasn't going to do.
Right.
That was why I was strategizing and saying, I can't come out my skin and tell this woman what I want to tell her because I need her to refer us to someone else.
Yeah. Yeah.
Sorry, Dr. Sylvester. I told myself I wasn't going to act a fool. I kept it together until this point. I was trying to tell this story without emotion, too much emotion. I want your audience to understand, but they have to understand that we have some we have a lot of responsibility in this too. We do.
No, I completely agree. I think that a part of it, though, is when you don't know your body, then it is easy to relinquish control to somebody that you think at least knows medicine. That's the problem, right? But medicine is best implemented when there's data about your body. And so we just have to own our data, right? And we have to learn how to use tools both proactively and to identify problems. And so it is where we come in, right? Providers that do not only have the time, but have the conviction that there are things that people just deserve to know. Whether the school system, the public school system, believes that it's important for people to know anatomy and physiology or not, they do. And so we just have to get out there and teach it, right? And so I want to talk about this. I want to talk about what we are going to do together. I want to make sure that you have gotten to everything. Yeah, I think that we discussed everything that I would love to come out in this story, because people just need to hear real stories. I think that sometimes, especially at this point in your postpartum journey, I did not expect to be talking to you at this point in your postpartum journey. But people have to understand, you don't hop on a call when you're less than a month. Well, the 12th, we're a little bit over a month out from being a mom to do something like this, unless it's something that you believe is very, very important. And I just want to say, while you gave an overview of what you do, it's so much bigger. The awareness that you bring to the problems that exist within the healthcare system, as well as the solutions that you bring to the forefront, are going to change the way healthcare is done. Whether it changes because healthcare providers change, or it changes because moms change, there's going to be a change had because people will be more equipped. They will be more educated. They will know what they need to know to sound the alarm. And no matter the facility, there will always be at least one who says, we will not ignore that person, right?
Mm.
We have to get to the person who won't ignore that person. And it takes fighting to do that sometimes. And that part, I think, is what breaks my heart the most, because some people just don't have that fight in them. They have so many other things going on at one time. They have so many other responsibilities to get back home to. They don't have assistance with childcare. And so the longer they're at the ER, the longer they're away from their babies, and they may be paying someone to watch them. And so resources, whether it's monetarily or it's time, like they just don't have it. We have moms who have no leave postpartum. Rebeca, Dr. Segraves, can you imagine Jenna going back to work a day after she delivered her baby? Can you imagine that? This is happening in places right here in the US where you go back day 1 and your blood pressure spikes day 5, and that's it for you, right? We don't even get the rest period here. And so I think when people say, what can I do? What can I do to help? What can I do to help? It's like, if you could save up for her to get 2 weeks off of work, if everybody can just, what is it for those people who don't have leave, paid leave? Because it's not enough to just be, I'm going to save your job for when you get back. My bills need to be paid, right? And so 2 weeks, can we just help moms for 2 weeks? And with cesarean deliveries, it really should be 6 weeks, but it's a lot to save up for 6 weeks, right? Worth of funds. But it's like, that's what's needed. Like, if we could just get some time to rest, to run back and forth, to get things investigated, to have just extra money in case things come up, to change our diets. Like, y'all luckily didn't have to change your diet. Jenna is across the board in the best physical shape possible to recover from this. And so I want people to hear what Dr. Segraves is saying is they are still in the throes of it. But what we know is that we are not going to stop until her diastolic blood pressure gets where it's supposed to be. We will not stop, right? Because there is somebody who can put her on the right medication so that we can get it down to where it's supposed to be. And then when she comes off, her lifestyle already will get her right back to where she needs to go. We just have to make it to that provider, the one who sees her like we see her, the one who treats her like she should be treated as an individual. And the reality is, with the numbers that she has diastolic, they're not even following the American Heart Association's recommendations right now, right? So there are recommendations that are out, and they are being completely ignored because she doesn't look that bad. Of course, she doesn't look that bad. Unfortunately, a lot of people in the United States are unhealthy. A lot of people are on high blood pressure medication. She is not one of those, and she will not be one of those for life under our watch. We're not letting it happen. But what people have to realize is the longer you do let it happen, the longer you're in the 90s, the longer the heart just accommodates for that, right?
It does. It does.
And so we have to really be on top of it and say, if you're not going to help, we'll move on to somebody else who will. If it's a cardiologist, if it's a pharmacist, if you have to continue to have therapies come into the home, if you have to do unorthodox or untraditional type medications or interventions, that's what we're going to do. Because each day is a day that we're not addressing an issue that we know is happening. So while it's not life-threatening, which is why nobody's making a big deal of it, it is quality of life-threatening, right? It just is.
Oh, absolutely. Yeah, I mean, the day that we were discharged from the hospital the second time after our hospital readmission, I contacted an occupational therapist who's been providing in-home care because mental health-wise, Jenna couldn't take her blood pressure without having this extreme anxiety. Like, she would feel this tightness, and I was like, we have to nip this in the bud. This is affecting a lot of different things. The back to the emergency department, the issue with the OBED, the high BNP reading, the scare of heart failure, all of it. I was just like, let's get an OT in here, because it was just getting to the point where she couldn't even stand, which is normal. We knew that postpartum mental health concerns were going to be an issue, but she couldn't stand to be in the same room with the baby, when he was crying and stuff like that. And I was just like, we have to just make sure that you're good and you can be functional. But knowing that, we had a cardiologist that I would say was not as bothered as we were about Jenna's blood pressure, it made me realize that people need to be taught that the heart muscle is not the same as your arm muscle, your leg muscle, your skeletal muscle. We want skeletal muscle when we work out to hypertrophy, to get bigger.
Right.
We don't want the heart muscle to hypertrophy, right? We don't want that to happen because it does lead to cardiomyopathy, right? And so we just didn't want those readings to be high. And we just realized very quickly after that second hospital stay that Jenna was not being treated as an individual. And so that's why I reiterate this, is that I can't see a scenario with what we know now as you not having you on our team. Right? Like, because you were providing us information that we just could not get from our medical team. And again, I say this because we are so well resourced. And so I'm not being ignorant to the fact that, I have friends that are single moms who have been through a C-section, who have been through a vaginal delivery, all of that. And I still can't imagine how they did it. And I don't want to imagine, because I would never want this to be normal for anybody, even based on what Jenna went through. She's a healthy woman. Yes, she's vegan. Yes, she's an ultra endurance athlete. And yet she still had the issues that she had. I could never imagine just not having you on our team and not taking, I took an extended leave of absence of work. I was able to do that. I understand that women are not. But to go into this thing without having a team and without having the information about your body, like, no, we have to know about our body, especially during pregnancy, where in and of itself, pregnancy is like running a marathon a week for 40 weeks. And then the postpartum recovery is very, very uncertain, for people. So you get a team around you, not because you're anticipating something to be wrong. It's because you want everything to stay right. You surround yourself with people in a team. And so I guess my last bit of advice really for anyone would be that birth registry. Let me tell you something. We didn't need half the things on there right now. We did not need a high top chair, right? I mean, he is 5 weeks old. He is not sitting up. Like, the stuff that is on there that we were just like, we have to have right now. We had to have the hiking bag that he puts in. You can't do that at 5 weeks. Like, the things that I would tell people on your registry is to put someone like you, like a service like you had. Like, if it was something that could just be added to the registry, get a postpartum doula, get a night nanny if you can, sleep. The biggest thing that we've seen when Jenna's blood pressure looks almost normal is when she's had rest. And you've been on me about that. I'm trying. I'm like, I will stay up with this baby as long as I can so she could sleep and get 5 straight hours. We like, I have you in my head every single night. Jenna needs to get 5 straight hours. And it is so hard. But the days and the nights that she does, her blood pressure looks like it's going and trending in the right direction, right? Without a change to her medication. So sleep is literally life's medicine. And so I'm just saying, I'm telling you, that baby registry, you don't need half of it. You don't need 8 glass bottles. You don't need all the bottles that are going to be like the breasts. You don't need all of it. You need 2 bottles. You need to wash them. Okay. You don't need 8. You don't need, all this stuff. I'm just like, if I could go back on that registry and I could put providers and I could put people, I would replace things with people. And I would replace the things that we need down the road with the people that we need now. The providers that need to be paid because insurance is not going to cover your services. We're just not there yet. And it may not even happen in our lifetime that insurance is covering your services. I hope so, because what you're doing, Dr. Sylvester, is you are saving lives. You saved Jenna's life. And I said that publicly You know, I've talked, I mean, I know that, yes, normally spouses and moms, they're not on a podcast this early out, but I couldn't wait. You saved her life, and people need to know that you knew more than the medical team. And so please don't go after like the degrees. Like we went after the highest degree individuals, and they told us to go home and walk 3 times a day, like for 10 minutes. Like, please, like be informed. It's like, stop putting your life in the hands of these people. Like they study textbooks for a reason. They're not looking at enough people, right? To do individualized care. We don't pay for that in terms of research studies and research institutions. We're not researching individualized care. And you said something that you really need to drop in this podcast. You said something about individualized care. Do you remember that quote? Standardized, individualized care. Say it again, please, Dr. Sylvester. I'm gonna be quiet. Say it again.
It's so true. Standardizing individualization. So instead of following protocols, instead of looking to standards, we need to, as a whole, standardize individualization. And once we start doing that, everybody will have exactly what they need, and nobody's symptoms will be ignored. Right. Yeah. Thank you for that advice you gave. And so we're just going to drop a little teaser at the end. So we are going to be doing some education directly to the community together, because we can't be in everybody's living room. Everybody's not going to have a watch on their wrist. But everybody, if given the information in a way that is practical and they're able to implement it, they can save their own lives, right? That's what we want, is for people to be able to save their own lives. And that's what we're going to do. So you and I, we will teach, and we will just continue to teach until people say, I get it. Right. The most beautiful thing happened last week. And I know I told you about this, but people need to really hear this. Did a video filming for how to use a blood pressure cuff. But it wasn't just that. It is, what is blood pressure? A lot of times people don't take it. They don't even know what it is. All they hear growing up is, you don't want high blood pressure, right? You don't want that. And then now they don't even know what high is, because we're waiting to get to 160 over 110 for it to be an emergency, right? And so explaining what is high blood pressure, what is blood pressure? What happens if it's too high? What happens if it's too low? Everybody focuses on high blood pressure, right? What happens if it's too low? How to take it properly? And for there had to be at least 50 readings during this filming. And this mom at the very end, she said, I have noticed that my blood pressure has been like in the 90s, and it hit 100 a couple times, and the bottom is always in the 60s. So based on what you taught me, I should be concerned if my blood pressure is like 125 over 75. And I said, girlfriend, if this is how easily someone learns, we are unstoppable, Dr. Segraves. Okay, we have had moms now, and I think we talked about this, who just put their headphones on. You want to talk to me during my blood pressure? No, thank you. I'm going to let you wait the 5 minutes that research says you should wait before I take it. And so we just have to get this information out. And we have nothing but time, right? We're still in our 30s. Time to change the game, okay? I
just turned 40, all right? You speak for yourself.
I'm right behind you. You are so right.
For yourself. I've got a lot of time. I do not. I live every day as if it's my
3 months behind you. Listen. No, you're January. I'm April. Yeah, so I'll be 40.
I'm telling you, I have no problem people knowing my age, because I will tell you this, is that yes, people should know, feet flat on the floor, back supported. No one should be talking to you. Arms supported. And in the cardiologist, I think Jenna even messaged you, back unsupported. Woman was trying to make conversation. Arm unsupported, feet dangling. I said, I'm holding this baby. And I just said, I can't do the cardiologist job, because this is the number you're going to see. And sure enough, it was over 90 diastolic. I'm just like, what else? What else do we have to do as patients in order to get the care that we need? We have to know everyone's job. And I'm like, no. Let me reframe that. We have to know our bodies.
Yeah.
Biggest job that you could do, know your body. Once you do that, then you know if whether or not the provider in front of you is doing their job correctly. When you know your body so well, when you know how to take a blood pressure properly, you could spot them a mile away. When you know that after 2 minutes, your blood pressure skyrockets and the provider in front of you, you need to go walk 3 times a day, 10 minutes. You know, this is someone you need to get away from. As you run, do not walk from that person. You run, don't walk. So absolutely, I'm excited to do education that is long overdue. I educate providers, hoping that the hundreds of lives that they affect, right, will improve. How much more valuable is it to educate the public directly, though, right? Because then generations will improve. You will teach your daughters, you will teach your sons. So to me, it's like this is a no-brainer that you've been doing this your whole career, is teaching people directly. I'm just now starting to pivot and just realize it is more valuable for the people going into these doctor offices, going into these emergency departments, God forbid, is to be armed with information, right? More than the person in front of you, right? So that you can really compare data points and not be at a disadvantage with only whatever data they're using, right? Which is not going to be individualized to you. So standardize individualization. That is the mantra I will follow, Dr. Sylvester. I cannot thank you enough.
I love you so much. You have no idea how your friendship, your love, your support, even before this, you were like this about Mist before, Jenna. But watching you defend and protect and love and fight, it changed me. Being afraid for Jenna changed me. Every minute that you were not texting me, I was praying for her. I was waiting to hear from you guys. I think that the other part that's missing is really loving the people that you serve, right? Not just when the person comes in, there should be something that clicks that says, this person deserves to be treated like I would want someone to treat me. And for every patient, every time, every person I've ever come into contact with, that is what I believe. That is how I feel. That is how I treat them. And for you to be family, not to be like family, but to be family. I was like, we are not losing this fight. We cannot lose this fight. I cannot lose my friends, can't lose my family. And so I am grateful that you trusted me, that we could do this together, because the only way that it works is if both sides are doing their parts, right? So thank you for hiring me to do my part, and for fiercely and with just a determination like I have never seen doing yours. Because the deaths that we see, the most recent one that we've seen, the ones that have been taking place forever now, they are preventable. They're preventable. And it's not another scan of the community for what resources are available. It is deciding that everybody matters. Everybody's life is worth fighting for. Even if as a provider, you're told, you just need to discharge that person. Oh, this person's been in and out of the ER. Nothing is wrong with them. You have to decide within yourself that you will treat them like you would want to be treated. So thank you for having me on your team. I love you. Okay, so everyone listening.
Thank you.
Thank you.
And I'll just do this, is just say their names. Dr. Janelle Greensmith, a midwife, a Black midwife who died a little bit after the new year of cardiac arrest after her cesarean wound dehisced, and she had to be taken back to surgery. And within a week of her C-section, she passed away. And I will say their names. and you will say their name so that we remember this is another life, another mom, another family, and another generation affected unnecessarily. Right? There's things that we can do. There are devices, there's data that you have that you showed and shared with us that was a direct contradiction to the advice we were given medically. You have that information. Everyone should have access to that. We're in a privileged position because we know you, Dr. Sylvester. So thank you for providing this service. But we can't ignore the fact that not everyone has access to it. And I don't know how to say this any other way, but I believe every mom should have access to what you're providing. There's just no other company that's doing it. Because if you go to just any remote monitoring, you say, okay, I've heard remote monitoring, and this watch tracks this and this and this. I promise you that company will not be tied to an individual who will call and text you. In the emergency department, you were texting with me, and it was 2:00 in the morning your time, because I know it was 12:00 in the morning my time. So I understand our time difference. And so I need to reiterate this, Dr. Sylvester, there's nothing on the market like what you're providing. And I don't know how sustainable for you, but I'm just going to encourage people that if they are facing a pregnancy or postpartum, just something doesn't feel right and a provider's not talking to them, or they want to go through this thing just successful like we did, no risk at all, very low risk, and they just want to have a successful outcome, is to get on with your services. Get on with Operation Miss, get on with the Mommy Monitor. It is just worth your time, and it's worth your money, it's worth your life, whatever. Like, get her on your baby registry. Like, get the high top table off. You don't need that until that baby can sit up. So, like, stop putting high top tables or chair top. You know what I'm talking about. Get Dr. Sylvester at Operation Miss on the baby registry. That's my time.
I love you.